history, we have a 71-year-old female patient who had an incidental finding of a 3-centimeter large polypoid lesion in the duodenal bulb. EOS showed an isoechoic lesion without infiltration of the muscularis propria, and histology confirmed a pyloric gland adenoma with low-grade dysplasia. The pyloric gland adenoma typically presents as an isolated polypoid lesion in the stomach, but also as in our case in the duodenum or in the gallbladder, pancreas, or esophagus. The problem is that there is quite a high transformation rate into adenocarcinoma that varies between 12 and 47%. So the indication for an endoscopic en bloc resection is clear. I will now show you a small video of the lesion. You can see here this large polyp in the duodenal bulb. When it is moved a little bit, you can see that it's semi-pedunculated. So now Professor Yahagi will perform endoscopic submucosal dissection of this lesion. The learning objectives for us are the endoscopic assessment of the lesion before the resection, the techniques of duodenal ESD, water saline pressure method, and new endosurgical settings as the technique of the underwater endoCUT, as well as strategies for defect closure.
Good morning, Suri. Good morning. So we are actually here with Professor Yahagi, and it's a big honor for me to be with this intervention with Professor Yahagi, and we have a big team here with Hanife, with Esther, with Sandra, and with the anesthesiologist who is doing the general anesthesia. And as you heard before, we have this duodenal adenoma, and we just already have a look at the lesion. And would you like to comment, like to characterize this lesion?
This is around 3 centimeter lesion located at the duodenal bulb, and as you can see here, it is relatively homogeneous surface structure, and there is no WOS. WOS means white opaque substance. When we use the NBI, if we see the whitish substance, which is the absorbed lipid, it usually suggests the intestinal type phenotype, usually benign tumor. But this region doesn't have any white opaque substance. That means this is gastric phenotype tumor, which has relatively higher malignant potential. That's why even taking biopsy revealed just a low-grade adenoma, it is better to remove it in an en bloc fashion to get precise histopathological evaluation. And this is a relatively tricky lesion because the upper part is relatively big, which is 3 centimeter in size, but the stalk is really short, semi-pedunculated. So going behind this lesion is a little bit difficult. And I have to start my procedure from the back side in order to make sure the endpoint of the submucosal dissection. I prefer to do my procedure underwater condition because we can float up the entire target lesion throughout the procedure. And of course, active normal saline irrigation makes it much easier to go into the submucosal space. Okay, let's start the procedure.
Can you just probably make a comment on the endoscope you are using, why you are using it, and
yes,
what is the plan for the resection?
Yeah, this is Olympus therapeutic endoscope, which is GIF H290T, and merit of this endoscope is 3.2 millimeter working channel located around 7 o'clock, and the water irrigation also coming very close to the working channel, which is 6 o'clock. So even I encounter severe bleeding, I can flush away the blood and stop it. it is relatively convenient. And the rigid part of this endoscope is relatively short, and the down angle is 120 degrees, which is also really good for the therapeutic endoscope. Okay, can I have injection needle? I would like to make a partial mucosal incision at the anal side first in order to make sure the endpoint of the submucosal dissection. Then I will extend the mucosal incision to the lateral side, and finally I will give additional submucosal fluid cushion from the oral side and quickly go into the submucosal space from the oral side and continue submucosal dissection. That is my plan.
Perfect. And the whole procedure is going to be done in an underwater manner?
Yes.
Good morning, everyone.
Morning.
So it's a pleasure to co-share from here together with Michal Kaminski from Warsaw. So my name is Horst Neuhaus. So this is a nice demonstration of a rare lesion. Would we do something wrong if we would do underwater EMR, because this pedunculated lesion could be easily removed with a snare, also in an en bloc fashion? So what's the advantage of ESD in this particular case?
Yeah, in case of having the lesion less than 2 centimeters, I also prefer to do underwater EMR, because the en bloc resection is also available with the underwater EMR. But unfortunately, size of this region is probably around 3 centimeters, which is difficult to catch entire lesion. And sometimes backside of the big protrusion cannot catch completely, and then it turns to piecemeal resection. Therefore, I prefer to do ESD to ensure the complete en bloc resection. So that's the reason why I'm planning to do ESD.
So now, Hisa, you explained, I mean, which kind of scope are you using, but would you select also a different one in any particular situation when the lesion would be not in the duodenal bulb, but further down in the duodenum or closer to the pyloric ring? I mean, I mean, what is the choice? How it is driven?
Yeah. I prefer to use this endoscope even for the lesion located at the second part of the duodenum, and even for the lesion very close to the major papilla. But sometimes there is strong undulation around the major papilla. In that sense, in that case, it is necessary to have much more strong down undulation. Unfortunately, this endoscope has only 120 degrees down angle function, but greatest Fuji scope, which is 840T or 840 TP, it has 160 down undulation. That's why I usually check the maneuverability and the location of the target lesion before starting actual procedure. Then reset the appropriate instruments for the difficult procedure.
We can nicely see the advantage of using a transparent cap, because you can keep the lesion away from the cutting zone. So which type of cap did you choose for this procedure?
This is ST food from Fuji. Because of the conical shape and the long nose, we can still visualize the entire area. And within the underwater condition, because of the magnification effect, it looks relatively short. So if we use standard straight food, it becomes very difficult to visualize the core part. That's why I prefer to use classical ST food like this. Okay, injection please. This is glycerol solution, which is a mixture solution of 10% glycerin. Okay, stop it, please. 10% glycerin, 5% fructose, and 0.9% sodium chloride.
Okay. So obviously, it's not necessary. Okay.
You will come to visualize the submucosal layer with the blue color.
So
approaching to the anal side is relatively tough because of the big protrusion, but I try to do my best.
Obviously, it's not necessary to mark the periphery with coagulation.
Difficult.
What do you think? Would it be helpful, like, to do a circular marking in this case? Or
it is not necessary because border of the lesion is quite clear. Now you can see the border here. We can easily recognize the neoplastic area and the normal background mucosa.
Okay. Oh, thank you. Thank you. Thank you for the demonstration. We would like just to switch to another room, and we come back very soon to see how.
Yes. Can you see the image now?
Yes. Yes.
Yes. I'm staying at the pyloric ring, and behind the pyloric ring, we can see the big polypoid lesion here, and the color of the big lesion becomes pale because I already dissected a certain amount of the submucosal tissue and shut down the perforating artery. But I found this really severe fibrosis at the central part of the lesion. Probably due to the movement of the big polypoid lesion, it induced muscle traction and severe fibrosis. Now I'm going to cut through there, and if we are lucky, we can cut here without bleeding. But majority of this kind of big muscle traction, usually there is a sick blood vessel inside, so we should be very careful. And before starting procedure, I would like to inject a little bit, okay, injection please, little bit hyaluronic acid with strong blue color to visualize the fibrosis. Okay, injection. Much more. Okay, stop. Then I would like to inject also here, injection.
So now, Hisa, how you differentiate fibrosis and thin muscle layer or muscle retraction in duodenum?
Usually, muscle retraction looks brownish. Injection, please. And just the severe fibrosis looks whitish or silver color sign. Okay, that's good enough. Okay, needle in. I injected a few milliliters of hyaluronic acid solution. As you can see here, injected solution looks like blue area, but still there is brownish area here. This is muscle. So I have to cut through part of the muscle layer, but it will be okay. Starting from the lower side and going up very slowly using precise sec. Okay, this is 1.5 millimeter size dual knife, which has very short needle tip. Therefore, carefully cut through here. Go slowly. Okay, then check the situation. Now you can see muscle fiber here. Now I'm cutting muscle fiber itself. Okay. Oh, luckily there is no sick blood vessel inside.
I would say that luckily there is no hole yet.
I can see the backside of the target lesion.
Okay, I think Horst and Michal, we all agree that something like kids don't do this at home.
Okay, I have to cut here and open the submucosal space. Now I cleared the most fibrotic area. Luckily, there was no sick blood vessel, therefore I can speed up dissection for the rest of the submucosal tissue. Still, there are some blood vessel here, but by using precise sec, I can minimize the bleeding occasion.
But
So
anyway,
now I
we
can
are
see
less
the,
nervous
left
than
side already.
in the past because we have now a couple of options to close defects. Huh?
Okay, good. So
Okay.
Naohisa, we have to
Yeah.
leave you.
Yeah.
Fingers crossed, but I don't think you need it. Thank you.
Yeah. Now it's almost the end.
Almost the end.
Actually, this is
Okay.
the end of the
Oh,
procedure. It's
Congratulations.
already finished. Oh, small amount,
yeah.
remnant.
Okay.
Okay, finished. Thank you very much.